So with that, I'm going to turn it over to the next speaker. I think Aaron Edwards is going to introduce Brian Kaufman. Thank you.
Good morning, everyone. It is my pleasure to introduce our first guest speaker for today's Pain Summit, Dr. Brian Kaufman. Dr. Kaufman received his medical degree from the University of New England College of Osteopathic Medicine. He is certified in internal and neuromusculoskeletal medicine with a subspecialty in pain. He has authored a chapter in the Foundations of Osteopathic Medicine, has published in the Osteopathic Family Physician Journal, and is currently serving as scientific editor-in-chief of the American Academy of Osteopathic Medicine Journal. Dr. Kaufman is a subject matter expert for the AOA Conjoint Pain Board, and prior to his specialization in pain management and addiction, he practiced primary care internal medicine for 10 years. Currently, Dr. Kaufman is an adjunct faculty at UNICOM, an avid musician, and doesn't call his mother enough. Thank you.
Thank you. That's true, you know. My mom would agree with all of that. Yes, especially that I don't call her enough. So that was a great introduction to today. I'm very honored to be here. I was very honored to get asked to speak to all of you. That introduction by Ian Meng and Ed Bilski was fantastic, and it dovetails really nicely into what I'm going to talk about. So the focus of this talk is going to be a case for opiates as a positive intervention for chronic pain. We all know about the negative side, but I'm going to hopefully, by the end of this short talk, convince all of you, if not some of you, that opiates should not be as vilified as they have been in both the media and in the legislature. So, with that, so we all know this quotation, pain is inevitable, suffering is optional. Very famous quotation. I'm not exactly 100% convinced that this author invented it, but certainly he has popularized it in literature. And in fact, he wrote the book, What I Talk About When I Talk About Running. And so this gets adopted frequently by chronic pain groups, by all kinds of different groups looking at how they can improve their lot. And when we talk about pain, we have to distinguish between pain and suffering. Okay, there is pain and there is suffering. This is a portrayal of a person who is suffering. We instinctively know by looking at their face, and we can recognize that this shows anguish, that this shows loss. These two, I don't think, were modeled after each other, but yet look how similar these two faces are. This is someone who has loss of a loved one, loss of liberty, all types of frustration and anguish. Chronic pain, suffering is not always optional. There are patients that I see that to tell them their suffering is optional would be like trying to convince them that the sky is red. And they'll look at you and say, what do you mean my pain is optional? I'm suffering here. I can't take it. And they mean it. A lot of times we have to step back, and Ed did talk about this. We have to step back and look at the person, look at where they're coming from and meet them where they are. Not everybody who comes into my office is where I want them to be. They're not going to be ideal. People are messy. Treatment is messy. So you need to meet people where they are. And in some cases, folks have been disempowered. They're disempowered by their disease, but also they may be generationally disempowered. They may have had parents who are disempowered. They may not know anything different, and they're coming for help. They don't know what to do. So these are two schematics, just looking at on the far left, the more of the social aspects of chronic pain, and on the right, more of a physiologic change in chronic pain. So if we look at some of the social aspects, people have an injury, they get into chronic pain any number of ways. They end up maybe having loss at work, maybe they lose their job, now they have financial woes, maybe they lose their insurance. They've been seeing doctors, maybe they can't afford to, now they have income problems. There's stress at home. They're going to the emergency department because they don't know what to do. They go to their primary care physician, and the primary care physician will do everything that they can to help them. But a lot of times it takes more than just one person, and it also takes specialized training and specialized knowledge to really intervene and help a patient effectively. On the right is more of a cycle looking at some of the changes. What you don't see in there is sometimes when people get hurt or they get injured, they get problems with the ligaments, they get problems with the tendons, the tone in the muscle changes. Over time, when they're having continual pain and chronic pain, they get permanent changes in the spinal cord and in the spinal column. At least as of today, these are considered permanent. Maybe that'll change with the use of ketamine and some of these other targets that neuroscientists and scientists alike are looking at. But right now, some of these changes tend to be permanent. They get a different physiology that becomes their normal. Oh, that came in too fast. So, medical system failure. So what happens when the medical system goes awry? So I'll go through a very quick scenario that I hear again and again. Luckily, it's not as catastrophic as this, but to whoever is dealing with it, it probably is. So let's take a fictional patient, okay? I have about 10 in mind that fit this scenario. Let's talk about Jim. Jim is a roofer, okay? Jim's been roofing for about 20 years. He's 35 right now. He started when he was young, working with his dad, who was a roofer. Jim smokes, but not very much. He lives in a decent house. He has a wife. He has a family. He's generally happy. He goes out on the weekends or spends time with his friends and his family, may have a couple of beers, but he's not an alcoholic. He works hard. And over the past 5 or 10 years, gradually, at the end of the day, he's having more and more pain in his back. Eventually, he had an injury. So he fell off a scaffolding and he had a fracture. He got treated, but the pain never got better. It just stayed amplified. After a while, Jim's boss fired him because he can't get paid to be a roofer if you're not roofing. So now he's out of work. He's been out of work for, let's say, 5 years already. He first sought treatment from his primary care physician and first went through NSAIDs and different treatments. Ultimately, he got placed on some short-acting opiates, oxycodone. And he took them as directed 4 times a day. And what he noted when he first started taking them was that he felt better. He felt better immediately. And he felt like he could do things. He felt a little bit like his old self again. He started doing things around the house. He started helping his wife. He started going out. He started socializing. But after a few months, they weren't working as well. And because he's doing more, he would have more pain at the end of the day. So he started taking a little bit more to deal with the pain. He started running out early. He called his physician. First couple of times, the doc said, yeah, I can understand that, and refilled him. After 3 times, the doc said, I think you're developing a problem with this. I think, we ought to start cutting back on your medication. So his primary care physician cut back on his meds and ultimately tested him the way we're all supposed to, doing a urine toxicology screen, and he showed up having something in there that he shouldn't. Because what he had been doing was supplementing his medication with something else, whether it's alcohol, whether it's another med from a friend, whatever it is. Maybe he went to the emergency department because he was really having a lot of pain and received something he wasn't prescribed. And so he gets discharged. So now he has no source of medication. He still has tons of pain. He was doing better, but now he's not. So he goes to the emergency department a couple of times. It doesn't take long before he's branded a chronic pain patient and a drug seeker. Well, he is seeking drugs. He's seeking drugs because he's looking for relief. But he's not going to get it after very long. A couple of visits and you're done, especially in this area. Southern Maine Hospital has been very difficult for chronic pain patients, at least as per my patients. So what happens? Maybe he starts getting them from another source on the street. Maybe he starts using heroin because it's inexpensive and he can get it. Now, here's the question I would ask you to think of. Is Jim suffering from an addiction? Is Jim having a substance use disorder? To me, he has not yet exhibited the signs and the symptoms consistent with that. He's just unfortunately suffering from the medical system failing him. So Jim finally comes into me, and hopefully I can listen to him and help him. So when these patients come in, and they have these long, very complicated histories, and they want to tell you, what I don't like to do is say it's all in your mind. It's like going up to this gentleman and saying, listen, you just need to learn to meditate, and then your pain will be better. You know, it's really just mind over matter. Pain is inevitable. Suffering is optional. Come on, get it together, man. I might as well be asking him to levitate. Okay? I might as well be asking them to levitate. And that's often what we're doing. So what's one answer? Opiates. It's not the only answer, but it is an answer. In a lot of cases, it may be the best answer if someone has all of the right components and they don't exhibit signs of a substance use disorder that's uncontrolled, if they don't basically have cautions or contraindications that make the risk of prescribing them worse than the benefit. So opiates can bring hope to chronic pain patient. That's why I couldn't help but put the word opiates up there. First, do no harm. So when patients come in, we're supposed to either not do an intervention if it's potentially more harmful than doing the intervention, but also on the flip side, we're not supposed to withhold an intervention if it's helpful based on fear or lack of information. Now, that's not the same as me saying, if you don't have the training, don't do it. If you don't have the training, by all means, don't do it. If you're not comfortable with a medicine, just like I wouldn't be comfortable with a chemotherapeutic agent, but I am comfortable with Humira, which is a medication we use in rheumatoid arthritis and other inflammatory and autoimmune conditions, but a lot of physicians may not be. You need to be comfortable with the tool you're going to use. It's not for everyone. You need training, and you need to apply it discriminately. You need to show your patients that we care about them and we're willing to treat them. I will treat people who have substance use disorders and addiction, who also have chronic pain. They deserve treatment too. Just because they have a history and the disease of addiction does not mean they shouldn't get treated for chronic pain. They're entitled to that basic human right and dignity like anybody else. And so I don't withdraw it, I don't hold it back if they're controlled, and we can control it and keep an eye on it. But it takes time, it takes energy, and it takes a lot of work. But you do small steps. You prescribe something, you get someone de-escalating in their pain, you take the edge off so that now they can start doing things around the house. They can start participating in their life. Some of their debility and some of their suffering goes away. They move in the right direction. We start unwinding that cycle. We let them come off the merry-go-round so that they're not just spinning around helplessly and hopelessly. So what do we do then? Well, we can address ligament issues, we can address posture, we can do all of these interventions that make a big difference. When people have been chronically debilitated, when people have been chronically ill, the ligaments get lax. They start sending signals that they're being strained or stretched at rest. and they shouldn't. It should only be when they're actually getting stressed or stretched. So we need to make those ligaments stronger. We need to tell them to kind of be quiet. We can address their overall structural issues, try and bounce around forces around the joint with osteopathic manipulation. This is one of the best tools that we have. And it's the only tool that addresses structural issues that I know of. Injections won't do it, epidurals won't do it, medications won't do it. Only osteopathic manipulation does it. It's the right tool for the right problem. Once those things are happening, you really don't have to encourage them too much to start doing their activities of daily living. They'll start doing them on their own. They'll come in very happy that they did their dishes, or they've been spending a little time in the garden, whatever it is. But they start moving more. They start participating. You can encourage them to walk, which I often do because it's easy, it's cheap, it's free, and it's one of the better interventions. Just walking. Get outside and walk around. Go see your neighbors. Walk around your town. We tell them to stretch. Stretching helps. Yoga. But, trying to get some folks who have no idea how to move their bodies to do yoga is a difficult thing. And if they don't have the training and they don't know this, again, you might as well be asking them to levitate. So small steps. Also, some people don't have the finances. They don't have the resources for these things. In an ideal world, I'd have everyone doing yoga with a certified yoga trainer who specializes in pain and getting CBT, counseling. I'd have everybody doing all of these things that we know work and help. But resources are a real issue. Not everybody has them. Not everybody gets them. In fact, as Ed said, not everyone can even afford medications. Sometimes I want to put them on certain medications that their insurance won't pay for. What do? You do the best you can. And I would just want to make a short piece about long-acting opiates. So recently the CDC guidelines came out and they were geared for helping address the opiate crisis. And they were specifically put out to help primary care physicians in treating non-malignant chronic pain. And they stress short-acting opiates still over long-acting opiates. In my opinion, long-acting opiates are superior to short-acting in many ways. When people take short-acting opiates that only last 3, 4, 5, 6 hours, we're setting them up for multiple doses in a day. Every time they're having pain, we're saying take a pill. That creates a pain reward cycle. That's not what we want. We want them to take their medication like they take any medication, like they take their blood pressure medicine twice a day. Set it and forget it, basically. But it's a change. They'll feel different. You do get a large dopamine response when you take short-acting opiates that you don't necessarily get with long-acting opiates. So that's different for folks. If you're switching them over, they're going to feel worse for a time till they get used to it because they're not going to have that dopamine. And dopamine is your feel-good chemical in your brain. So all of a sudden, they feel worse. Doc, it's not working. I feel worse. I'm going backwards. What are you doing to me? And you got to just stick with it. They last longer, they're more effective, and they're better indicated for chronic pain. If someone has a chronic condition, you don't give them short-acting anything. If they have high blood pressure all the time, I'm not going to tell them to take a blood pressure medicine they have to take 6 times a day. That's ludicrous. No one would want to do it. So just a quick thought about addiction and dependence. It's about behavior. So it's not about opiates. It's about behaviors around opiates. It's because as per the numbers that we saw before, 2.2 million or 2.5 million out of 100 million Americans, when they're exposed to the opiates, all of a sudden feel like things make sense. Some of the issues that they're having, not physical, but now we're talking more emotional, mental, go away for a short time. They feel good. That's not a bad thing. We all want that. We all want to feel normal. We all want to feel good. The problem is opiates are not a good way to treat that. We don't like treating depression. We don't like treating past trauma with opiates. They're not effective for that. But that is how they get used and misused. And that's the problem right there. And we have to recognize that. But it's about behavior. How many of us know people with drinking problems who stop drinking, but then all of a sudden they start doing something else? Maybe they're eating too much. Maybe they're start smoking more. All kinds of things. So addiction is about behavior. It's not about opiates. It's not about gambling. It's not about sex. It's not about other medications. It's not about eating. It's about behaviors. And we have to recognize those. And that's where it becomes tricky. It becomes tricky treating people who have both, and it becomes tricky treating people who don't have both, who you just don't know. So we look for the signs, okay? Training, look for the signs. So, the angry mob has spoken. Opiates are the evil, and we're now legislating what the CDC guidelines put into place for primary care physicians now are laws. So now we have laws in the state. So we're working on supply side economics. We're trying to decrease the supply, because if doctors were not prescribing so many opiates, there certainly wouldn't be any opiates on the street, and no one would get addicted, and we'd all live happily ever after. But that's not actually how it works. It's an easy solution, but it's not the right one. It's tying my hands, and I'm the specialist who does this. I'm not a primary care physician anymore. But I still have to now I'm getting everybody's patients in the area, because I work in Wells. I'm getting everyone's patients who they don't want to prescribe opiates for. And I'm unfortunately bound by the same laws that have been passed. So I think the solution is work on demand side. It's not the supply, it's the demand that's the problem. Decrease demand. Destigmatize addiction. Let people who have a problem come forth and say it without fear of becoming stigmatized. Let them come forth and get treated and have the funding and the resources to treat people. If we put our efforts there instead of prohibition, which has never been shown to work, I think we'd be a lot more effective. And I also think you'd see that addiction and substance use dependence and substance use disorder should be treated like a medical condition, not a legal or a social condition, and certainly not treated like a character flaw. So last thoughts. This thing goes fast. I look at prescribing opiates as I'm doing my patients a kindness when they're disempowered and they have no resources and no choice. That doesn't mean that I prescribe to everyone who comes in. It just means if they meet the criteria, and remember, the people seeing me have already been through the system, sometimes for many years. They've tried everything. They come to me and I say, well, let's try some ibuprofen. Let's try some physical therapy. These things are not going to work. So I use it as a tool. It takes advanced training. Not everyone should do it if you're not comfortable with it, and that's fine. You need to pay attention to details. That's why I stopped doing primary care, so I could do this only, because it takes a lot of work and a lot of infrastructure. And lastly, if all of your patients love you, you're prescribing too many controlled meds. So, thank you. Any questions? Sure. Does anybody?
We take some questions. I think we have another microphone, and it's important to speak into the microphone. We're streaming this and recording. Anybody want to take a question?
Any questions, folks?
Ernie down
Hi, I'm Ernie Merritt. I facilitate Southern Maine Chronic Pain Support Group, and I really appreciated your presentation. One question: when you prescribe an opioid to a chronic pain person, do you think it's should have other tools also like therapy or counselor involved, so the psych part of it is addressed also?
Absolutely. Whenever I prescribe, it may be the first thing that I do, but it's not going to be the only thing that I do. But if someone comes to me, and they've been under treatment and maybe their doc just closed their practice or whatever, and they're stable, that's one scenario. And then maybe we could jump into whatever treatments they're not doing. Because I feel like they should always be working towards improving how they're doing, whether it's through therapies, physical, mental, emotional, whatever it is, whatever the areas we need to concentrate on, smoking cessation, all of those things need to be part of the treatment plan. If they come to me and they've had no treatment for a while or no treatment period, then often I first need to de-escalate things. We need to start working together for a good couple of months before I start really pushing them into other avenues of treatment. But ultimately, we get there one way or another. Absolutely. That's an important piece, and I'm glad you asked about that. Yeah.
Hi, I'm Dale Mallory, and I co-facilitate the Southern Maine Chronic Pain Group with Ernie. And I've been in chronic pain for over 23 years. And I've tried, like you said, everything. Well, I found a doctor who really Ernie has gone to a couple of visits with me, and he sits down, doesn't even look at his file, and he talks to me. And that means so much to have someone that'll sit and listen to you. I mean, I always tell this story. I had one doctor, he walked in the exam room, had file in one hand, his hand on the doorknob, and I asked him if he had someplace to go. And he goes, "Well, why are you asking me that?" And he goes, "Well, your hand's on the doorknob. Come sit down, talk to me like a human being." Now,
That wasn't me, right?
I'm sorry?
That wasn't me.
No, I have never seen you before.
Just making sure.
At least that's what you pay me to say. It's okay. Okay, my other question has to deal with this new law. My pain doctor prescribes me 75 4 milligrams of Dilaudid. I get that prescription lasts me 9 months.
Okay.
Okay, I mean, I was on 450 milligrams a day for over 6 years, and I hated it.
Yeah.
And I only take it when I absolutely need to. And he knows this. Now, is he going to have problems prescribing that same amount of the Dilaudid now that that new law is in place? See, I don't understand what the laws are now, I guess, is my question.
From what I understand, the new law wants a 30-day supply of opiates, 30-day supply, to be less than 100 morphine equivalents.
Oh,
Okay, so your 9-month supply would be well over that.
Yeah.
But your 4-month supply would not be.
No.
So your monthly amount probably is not going to go over it. He may need to give you monthly increments.
My problem is he's in Scarborough, and I'm only good for about 20 minutes in the car,
Yeah.
and that's it.
Yeah.
So, and you have to go to the doctor's office and get the written prescription now. You can't call them in, you can't fax them. And
two things about that.
Yes.
I'm not. One, we're moving towards electronic controlled prescribing.
oh,
It
great.
doesn't mean, never see your doctor, but it does mean they can send in a prescription electronically for a controlled, controlled 2 substance. The other thing is you are able, especially pain specialists, can petition or do a prior authorization and ask for a waiver of that limit. Okay, so I've been told by the head of the Maine CDC that I will be able to get patients approved if I provide, adequate documentation. It's a lot more work on my end, but it should keep people where they need to.
But as long as it's been documented in your case file, that should be I mean, I've been seeing this guy since I moved up here from Rhode Island in 2001, and I've been seeing him for a long time, and he is
Yes.
great. And I'm just hoping that things aren't going to change that drastically, because, I mean, I have a serious problem driving to I live in Arundel, and I drive to Scarborough very infrequently.
I hope they don't change worse for you, too.
Thank you.
Yeah.
I appreciate that. Yeah.
The thing about prescriptions and trying to do it online, the VA does that now. It's a secured message system on the Healthy Vet, and it works great. It's still a 30-day supply, but it works great. You don't have to go get the script. Of course, that'd be in Augusta. Thank you.
Absolutely.
Thank you very much. We're going to move on to the next speaker. All right.